I recently went to an airway health dentist to get evaluated on my own airway health, and that is a topic for another episode. Maybe I'll dive into that at some time. But I bring that up because I mentioned that I had Dr. Shereen Lim on the podcast and got to dive into oral motor health with her as it relates to babies and breastfeeding. And this airway health dentist was starstruck. He mentioned her being famous in the airway health world, which is why I am so excited to share this episode with you about airway health as it relates to breastfeeding. Welcome to the Milk Making Minutes. I'm your host, Lo Nigrosh. I am also an international board certified lactation consultant and a childbirth educator, and I am on a mission to help feeding our babies be much easier than it often is for so many of us. Enjoy. Hi, Shereen. Welcome to the Milk Making Minutes. I'm so glad to have you back.
No, thanks again for having me.
Yeah, so we recorded your personal baby feeding stories already, and now we're going to be talking about airway health in our children. A lot of people might wonder why a podcast focused on breastfeeding support is featuring an airway health dentist, but we'll get into that. So everybody stay tuned because it is very deeply connected. But before we do, why don't you go ahead and reintroduce yourself for anyone who is coming to this episode but didn't hear your personal story.
Yeah, well, I'm a general dentist from Perth in Western Australia. I developed a special interest in breathing and sleep because of my husband's snoring. And I became involved in that area, I realized snoring and obstructive sleep apnea, they're linked to a whole host of increased health at risk and reduced quality of life. And yet what we're doing, or what I'm getting trained at as a dentist, these oral appliances, is just a Band-Aid solution for poor jaw development. So I
Mm.
wanted to know, how can we develop jaws properly in the first place? We can have options like early interceptive orthodontics to get jaw development back on track. But if we recognize that form follows function, we really need to be intervening in the earliest years of life when the jaws are growing most rapidly to optimize sucking, swallowing, and breathing. And so this is why I've become involved in breastfeeding advocacy and promoting the mechanical benefits of breastfeeding and the impact on jaw development, as well as looking at how the mouth structures are working during all the other functions and how the mouth is growing.
Yes. When you see lists of the benefits of breastfeeding, I don't
Mhm.
know that I have ever seen mechanical function of the jaw and mouth and tongue listed as one of the benefits, unless it is an IBCLC or some other professional pediatric dentist or possibly an ENT who has really dug into breastfeeding and tethered oral ties. Anyone who I know who is well versed in that sometimes knows the connection, but not always. Why do you think that we have not talked about this before? Has it not been studied until more recently, or is it that those studies did not get paid attention to?
Yeah, typically when we're assessing breastfeeding, we're really looking for, um, is there an absence of pain and is there good weight gain? But now we're really looking more at how well is the tongue functioning, because there's more research now to support that when we do not have a well functioning tongue, that will be linked to the development of sleep disturbed breathing and obstructive sleep apnea later down the track. Because our tongue, the bulk of our tongue is formed by the genioglossus muscle, which is our main upper airway dilator muscle. And it means we need really good tone and really good resting tongue posture, like this suction to the roof of the mouth, for that to keep our airway or throat open, particularly during sleep when things are more relaxed and floppy. And so, because of our understanding of the important role of good tongue function for healthy breathing and sleep, we've now been able to work backwards and see that if we don't treat a tongue tie, for instance, early on in life, it may be linked to the development of these other problems and poor palate development. And so we really need to pay more close attention to how the tongue is working during breastfeeding and optimal mechanics. So, for instance, for most efficient transfer of milk, it requires tongue suction, where the tongue is lightly suctioned to the roof of the mouth, and as that tongue drops, it creates a vacuum, and that's how milk is expressed most efficiently. And so when we can coordinate this, that tongue is really sculpting the roof of our mouth and making it broad. So that's why breastfeeding is sometimes called nature's palate expander. And as well as that, it's requiring that complex coordination of movements and that back and forth action of the jaw, which is actually stimulating the lower jaw growth. So it's really actually stimulating forward development of the face. And it's really the only way that we can suck, swallow, and breathe at the same time. So it's promoting nasal breathing compared to a bottle where we cannot do that all at the same time.
I would love to know what you see in the jaws of babies who mostly bottle feed versus what you see in the jaws of babies who mostly breastfeed. Are you able to see differences in their oral motor development down the line?
Yeah, I mean, not necessarily, because I think a lot of people are breastfed, but there's actually a lot of red flags that feeding was not going optimally that we missed. So I do think that even a lot of breastfed babies, they still have a lot of oral
Mm,
dysfunction.
mhm,
But one thing that I can be quite clear about is I definitely can see a link between oral dysfunction and, for instance, a high palate at
mhm,
infancy. So when babies are born with a high palate, it is usually possible to determine that there has been oral
mm,
dysfunction, even in utero.
mm,
So that's one thing that I can see a clear connection. You know, the babies that have their mouth open and their tongues down, or they've got very low tone, they're going to tend to present with these high and narrow palates. And even when we have a baby with a tongue tie and their tongue is actually sucking pretty well, there's just a restriction. These are the babies that may have a broad palate. So there is some sort of connection between oral dysfunction and the way that the jaws develop. And if we look at Christian Gimeno, he was the pioneer of obstructive sleep apnea and one of the sleep medicine pioneers. He actually has found, looking at fetal echography studies, that there was a link between the shape of the palate and the lower jaw and how well the muscles were working during sucking, swallowing, and breathing. So we know that there's a lot of genetic conditions that may predispose people to sucking and swallowing abnormalities as well as low muscle tone. But even things like tongue tie, there is a link between the oral dysfunction and how that palate and jaw are expressed before a child's even born.
Wow. And why do parents typically come to you with their babies or their toddlers or even their children? What are the things that are happening for them to come and want to get some help with airway health?
Yeah, so usually when I see babies from infancy, they're usually referred because of breastfeeding or bottle feeding problems. There may be painful latch or difficulties with a baby staying on. And they may also have some sort of sucking and swallowing air and reflux like symptoms where a baby is feeling very uncomfortable, gassy, throwing up, needing to be held upright during infancy. And then as children get older, it might be more issues with mouth breathing, snoring, having very disturbed sleep, and the behavioral problems that may be linked to. They may have difficulty chewing and swallowing foods, or they may have ongoing speech concerns where they have been to speech therapy for multiple years without getting much progress. Or they may even present to me for orthodontic problems where there's a concern with a crossbite or the teeth are very crowded. And then when I go into adults, it's more like they may have breathing difficulties or disturbed sleep. And quite often they'll have chronic neck tension linked to the compensation. They're using their neck muscles to get their tongue working during functions
Wow.
to overcome that tongue mobility. And sometimes they'll have myofascial pain or trigger points that refer pain to their head, and then they will have headaches as well.
Do you find that parents come to you saying, "My child is snoring," or "My child's having these behavioral difficulties, and I have heard or read that airway health could be connected"? Or do you find that somebody else who you have connected with, another provider who now understands this importance, is usually referring to them to seek advice?
Yeah, I think it's a very big
Okay.
mixture of things. I do get a lot of referrals, whether it be from other healthcare professions or other parents that have seen great results and they want to tell their friends about it. So there's definitely a lot of referrals, but also even parents are just so much more educated and empowered now, and they actually sort of looking for a particular type of provider. Huge variety.
Okay. And you ended up, from your years of experience and your deep passion about this topic, you ended up writing a book called Breathe, Sleep, Thrive. How long were you thinking about writing such a resource for parents before you did it?
Yeah, it took about 6 years to write the
Wow.
book because it's actually quite a lot to connect for parents, and I needed to do it in a way that was going to be engaging rather than sounding like a textbook.
Mm,
Um, really, I wanted to take parents on that whole journey that I went through, dealing with those adult problems and the despair that you see with people that have had these issues for decades. What are the warning signs that things are off track so we can intervene earlier?
mm,
Um, and yeah, that was probably my biggest holdup, was actually making it as relatable as possible, not so textbook, like to be able to really help them on that journey. Even when I started to learn that healthy jaw development is really important and we can do orthodontic treatment, but then starting to recognize, gosh, we can actually intervene much, much earlier from
mm,
infancy. We really need to be paying close attention to the way that the muscles are working, because that stimulates how the jaws are going to grow, and those jaws are growing most rapidly in the first 6 years of life. So I really wanted to be able to take that parent on that journey to really give them the big picture and work backwards. This is why we need to pay attention. This is what you can do. Here's the other options that we can now go to, because there's no one intervention that is going to fix or cure a child from the beginning. Even if we do release a tongue tie in infancy, there's often other things that we'll need to do to optimize those functions. So what is really key is restoring nasal breathing
mm.
for children and adults.
Yes, and it's really, I don't know how, you probably know how many pages are in it, but it's a quick read and it's really engaging. I was surprised at how interested I was in reading it. You know, sometimes you get a book and you're like, well, I really need to read this so I can learn more about this topic, but it's not so fun. But it's a fun read in addition to being highly informative, because there's a very narrative approach to it that makes it very approachable for parents. Yeah, 167 pages. It's not huge, with tons of references in the back. But I wanted to ask about this idea of the palate. You kind of mentioned that if the palate is wide enough and shaped properly, that even with tethered oral ties, we often see better oral motor development. So do you think that there should be a shift in focusing on really evaluating for the palate from IBCLCs and OTs and other people who are helping parents with feeding difficulties?
Yeah, absolutely. I think the palate, we sort of overlook it because really that palate is the floor of the nose and it's the house for the tongue. And so if you want things to work really well, we need to have good tongue space. And so I do think that a lot of the time we can't really intervene with poor palate development until a child is, say, 3 or 4 years old. So if we identify that high palate in infancy, depending on the degree of the constriction, it might not be possible to get optimal tongue function, even with a tongue tie. And we've got to make an individualized assessment for each child. How much difference is this going to make to improve the tongue
Mm,
mobility? If it's a very obvious tongue tie and very restrictive, there's still value in doing the tongue tie release to improve that mobility and allowing that tongue to function well for the next few years of life, even if we have to redo or do another procedure down the track. But if we've got a baby with very low muscle tone and their suck and swallowing is not particularly good, we would be more reserved in making a recommendation till we could see some improvements with some sort of prehab as
mhm,
well. That we need to look at the palate and also consider these other factors that could contribute to the outcome. And really, when a child is around that year age group, we have more options. When we can widen that palate, really improve nasal breathing, improve tongue space, it becomes a lot easier to get things back on track.
Yeah. And are there interventions that can be done? Like, often I'm teaching parents finger exercises to improve the mobility of the tongue and improve suction strength, improve the cupping of the tongue. And I know often I may have somebody kind of rub their finger back and forth on the upper palate. Do you see that there is a connection between these sorts of interventions and improved development as the baby grows? Or is it really that it needs most often an orthodontic intervention if the palate is high and maybe even indented? What do you see?
I think it could be variable how much those interventions or those exercises could make a difference depending on the degree of constriction of the palate. There's a point at which that palate is so high and narrow that it becomes very difficult for that tongue to fit in and stimulate the growth center, which is that mid palate suture. So I do think that for a lot of children, I highly value the role of palate intervention, even if it's only for half a centimeter, to know that we can get that back on track. I don't overlook that, and I think it has a very valuable role to play for a lot
Mm.
of children if we want to promote health. But yes, I do think that there are some children that it's not as significant, where it may play a difference and it may be quite impactful. And either way, if we recognize that what we really want to do is optimize structure and function, anything that we can do to get things back on track or stimulating and working better, I do think that's really important. So whether we can actually reduce pacifier use, because that will tend to alter the normal tongue posture, or doing things like the BB Munchie, which is a chewing device, or the oral exercises and getting that tongue lifting better, getting children to close their mouth and promoting nasal breathing, all these things will make a difference. And even things like osteopathic treatment, chiropractic treatment, when we have a very narrow, high palate, it's a distortion of those bones, which is connected to the rest of the skull. So if you can release some of those strains, that can allow things to move in a better direction.
Yeah. I'm glad you mentioned pacifiers because I had one question. I think there was a point in your book where somebody had asked you a question if a person is going to use a pacifier, what is the best shape? And you mentioned a
Mhm.
flat shape. But IBCLCs, we always recommend a rounded pacifier because it leads to more cupping of the tongue and being able to get a wider latch onto the pacifier. So I was curious, but I don't think there's a ton of research to indicate. We can just see the way tongue function works in a baby on the different pacifiers. And so that's why we've tended to lean towards these rounder shapes. But I was curious to hear a little bit more of an explanation of why you prefer the flatter ones. Is it because the tongue can rest more on the top of the mouth?
Yeah, I don't generally tend to
Mhm.
recommend it because in the book I have written some of the pacifiers are promoted as orthodontic pacifiers because they're quite small, but there's actually been a class action against that particular company because it's not research supported. I think that any pacifier will interfere with normal tongue posture. And so, really, it's really hard to promote which pacifier to use. Generally speaking, I think soothe and remove. If a baby really is quite reliant on a pacifier, we've got to work out what is the underlying reason, because a lot of the time, if they're sucking and swallowing air and they're quite uncomfortable, sometimes getting that addressed can actually reduce reliance on a pacifier. I think that generally speaking, the more deformable a pacifier is, that could be something to look at.
And when you say soothe and remove, you mean not ensuring that the infant has plenty of times throughout the day where they're able to have their mouth closed, have their tongue in the resting posture, which is at the roof of the mouth right behind the teeth, so that they are able to develop oral motor function properly because typically we wouldn't be sucking on something 24/7. And so if they always are reliant on that, then there could be some underlying root causes.
Yeah, it's not something that I even knew as a
Mhm.
dentist, that when we introduce a pacifier, the longer the duration and the longer the frequency, we're actually altering the tongue
Mm,
posture and altering the way it swallows, and we're altering the way that their palate
mhm.
develops as well. So I think it's important that we educate parents about it because I didn't know about it. I thought it was about the teeth. So as long as parents are aware of it, then we can actually make more informed decisions. Because I remember when my oldest was young, I said, "Oh, the pacifier seems to make quite a bit of a difference. I'm able to get my shower done." And they go, "Oh, why don't you go to Woolies and you can buy these cherry dummies? They're only $1. They're really big and bulbous." And that's what I actually did. I just followed the
Mm.
recommendation to get that. So I think it's important that parents have all that information so we can make better
Yeah,
choices.
exactly. And then the other thing that you mentioned, which I would love to touch on before we see if there's anything you really want to get to, is excessively fussy babies, kind of colicky babies, babies with lots of gas.
Mhm.
I feel like there's this perception that this is just within the range of normal baby behavior and that some parents just get all the short straw and they just have to deal
Mhm.
with this fussy baby. But typically, when babies are so colicky, there is an underlying root cause and it's often related to feeding. Do you see a lot of parents who come in long after the fact and they report their babies were that their children were very colicky or fussy or gassy as infants?
Yeah, look, this topic is something that I'm super passionate about. The topic of air induced reflux, or when babies have reflux like symptoms, not because of acid reflux, but because they're swallowing too much air. And these might be babies that are always coming on and off or clicking. They actually make a lot of sound, or there's a lot of milk leakage. And many of these babies are medicated with reflux
Mhm.
medications, but it make a difference. And we know that antacids in infancy is linked to increased risk of bone fractures in early.
Mm.
And what we're really missing is when we're medicating babies with these reflux medications, we really need to be checking the latch and how optimal is that latch and just ruling out the excessive intake of air. Because the medications don't work for a lot of these babies if we don't address that oral dysfunction. And there are so many papers now, and there's many listed in the book that actually demonstrate a link between air intake and tongue ties, these reflux like symptoms. So it's really important not to overlook this because many children with these symptoms are getting thickeners or changing formulas and they're going round and round in circles. And someone at the hospital may have said that there is a tongue tie, but it's mild and it's unlikely
Mhm.
to create problems with it. And you know what? A lot of these babies, it's really hard for parents. It's very stressful when your baby is always crying, can't sleep, you're not getting any sleep. This baby is really uncomfortable, and this issue is being totally
Yes.
overlooked. And one of my favorite things is when a parent can come in and have this addressed, and then they've gone, I have a better
Mm.
baby. I can actually enjoy my
Yes.
baby. Yes, see that a lot. And then when I'm seeing the older kids that come in and we go through their functional history, what was feeding like, and they can actually describe all these symptoms. And then for the first time, we can actually identify that there is a tongue tie. I have a lot of parents that actually start crying
Mm.
because they're like, there was a problem. No one listened
Mhm.
to me. So I think this is an area I'm super passionate about promoting more awareness about this link that we must not overlook tongue tie and air induced reflux or air swallowing when children are about to be prescribed a medication.
Yes, and so often I hear from parents who say, "It did not feel normal, but everyone was just telling me she'll outgrow it. This is in the range of normal. There's nothing to be done." And my heart just breaks because these well-meaning people just don't know what they don't know, and human infants of any mammal, they're not supposed to cry all day. So if they're uncomfortable and crying all day, I always encourage parents, trust your gut. If it doesn't feel right, it's probably not right. But it's so hard when you're asking and nobody is giving you an answer that seems to make sense or feels like it's the right way to try to intervene. It is so hard for parents. And then you
Mhm.
mentioned behavioral concerns as the child gets older. What are some of these signs?
Yeah, ultimately, if our tongue is not working well during breathing or sleep, if it's not sealed to the roof of the mouth, that tongue is going to be the back of the tongue, the base of the tongue is going to be quite flaccid and more prone to blocking the airway. And so we may have symptoms like mouth breathing, snoring, restlessness during sleep, children who are teeth grinding, bedwetting. They're prone to unexplained awakenings, or they wake up and they feel not refreshed. But during the daytime, when children are not getting good quality sleep, this may play out with concerns like poor attention and concentration, or difficulties with emotional regulation, or terrible twos, this tantrums where children's behavior often gets dismissed as quite normal, but they may actually not be managing as well because they're not getting good quality sleep.
If somebody they're hearing this and they're thinking, my baby definitely had difficulty feeding, and that could be either bottle or breast or both. I didn't have great milk drainage. Someone told me I had a mild tongue tie. My baby had a mild tongue tie, and now they still wet the bed. They have been diagnosed with ADHD and they're really young based on behavioral concerns. They do snore. They are a mouth breather. If they're hearing all of this and connecting the dots, what do you advise them to do as a first step?
Yeah, again, this is another area in healthcare where I think before we medicate children for ADHD type symptoms, there is so much research to support a link between breathing problems during sleep, and even research to support when these airway issues are addressed, we can get improvement in ADHD type symptoms. So, what we really need to do is we need to check to see that children are breathing well. And we want children to close their mouth, breathe through their nose. They should look very rested. They shouldn't be tossing and turning or sweating. There's multiple avenues because when we have an airway problem, it's very multifactorial. It's not really one thing that we need to look at. And so we want to look inside the child's airway for things like obstructive adenoids or tonsils or any congestion that could be narrowing the inside of the airway. But then we want to look at the outside of the airway, which is really formed by the jaws, to make sure that jaw development is on track. And then we need to consider the muscles. How well are the muscles working? Because we want children to have their lips closed. And sometimes, if they have been mouth breathing for many years, it doesn't matter what intervention you do to improve the airway structure. We need to retrain that behavior and get them to use their nose again. And we want that tongue lightly suctioned to the roof of the mouth. So if the mouth has been open for some time and the tongue's been sitting low, we need to get that tongue back up, because when that tongue is sealed to the roof of the mouth, it's impossible to mouth breathe, and that tongue is going to be working well to keep the airway open during sleep. And so sometimes we need to look at the role of tongue tie, but we also need to encourage good tongue tone and good tongue patterns. Sometimes when children are maybe the toddler age, it may be more easy to do things like remove things from the inside of their airway to buy a little bit more time. But definitely, as they're getting older, we want to have a jaw evaluation and see what we can do to get the jaw structures tracked.
And how do people go about finding the airway health experts in their area if they feel like they want to
Yeah,
start this journey?
it is also quite tricky, definitely, because people are always reaching out to know where to look for. Definitely, there's a lot of directories, things like the AAPMD, American Academy of Physiological Medicine and Dentistry, or Airway Circle, the Breathe Institute. These organizations, they all have their own directories, which will have professionals who have been trained in this area, and they might be like a lactation consultant or a chiropractor, an osteopath. What if you try to find someone in your area, they may be connected to people that they work with, so that could be a good step to look for.
Yes, just find the one person who's not going to look at you like you have two heads and then go from there, because you're right. They if they are passionate about this topic, they are going to be connected to other people in their area. Is there anything
Mhm.
else that you, before we wrap up, that you want to make sure my listeners hear about this airway health dilemma and how they ensure that they and their kids feel as good as possible and lead to good sleep and good breathing?
Yeah, it's not always easy because it's never one intervention that sort of fixes everything, but to just get really educated as you can to be able to understand all the different pieces. The book was actually to help fill that void, to give parents an overall perspective. One of the other organizations that I'm really interested in is the Children's Airway First Foundation, CAF. I think that organization is really doing a great job of compiling all different resources and podcasts for parents to listen to. So a lot of information is getting out there. So try to equip yourself with all this information so that you know what are the various
That's great. I'll
options.
have that linked in the show notes. And
Mhm.
we'll definitely have your book linked in the show notes, Breathe, Sleep, Thrive, and how people can connect with you. So that will all be there in case people want to reach out, connect with you on social media, or get your book and start learning about these topics so that you can then approach providers in an educated fashion and discuss your concerns. I thank you so much for spending this time, both talking about your personal stories and about this topic that you have devoted so much time to. It's really great to talk to an expert in their field about topics that I feel passionately about, but don't have the same expertise. So I really appreciate you sharing your expertise with me and with my listeners.
Yeah, no, Laura, I really want to thank you for what you're doing as well. I having had listened to your podcast with Jennifer from REM Masters, I think it's so wonderful to see lactation consultants really understanding this very important role that they can have in that early years of childhood to really help set up a better trajectory of oral function and sleep and breathing for life. So I really appreciate what you're doing. My lactation consultant colleagues that can make these discussions with parents. They're really the people that are going to be able to help parents know what to look out for as well. So thank you.
Yeah, it's hard because sometimes when you recognize that you don't know what you don't know, it feels hard to guide parents. But as long as we just know other people that we can connect parents to, we all have to collaborate and work together to make sure we're filling in the gaps for each other. I've really become passionate about this topic, and I love getting to speak with people who can fill in the gap in my own knowledge. So thank you so much. Bye.
Thank you. Bye.
So, what do you do now? I highly recommend you go click on the link in the show notes and check out Dr. Lim's book, Breathe, Sleep, Thrive. It's short and it's filled with lots of practical advice about how you help improve oral motor function for yourself and your family. Start with a quick Google search for airway health specialists in your area. Airway health dentists, in particular, have sought out additional training and are able to put all the pieces together to help you understand what the next best steps would be. Now, if you're thinking about this for an infant, the first step is to reach out to an IBCLC. Whether you're bottle feeding or breastfeeding, pumping, feeding directly from the body, we can help you determine what is the root cause of your baby feeding difficulties. Is it oral motor dysfunction or is it something else? I would love to be the person that helps you start navigating this and then connect you to other specialists in your area as needed. So please go to my website, www.quavinbirthservices.com, where you can sign up for a consultation. I can do oral motor assessments, both in person and virtually. Talk to you soon. Bye.